And now we have the keynote lecture from Professor Misra. He'll be talking on new obesity definition for Asian Indians.
Thank you, Ritesh. It's wonderful to be present in front of 350 people on Sunday morning. Excellent crowd and still standing at the back. And I'm happy to present this topic in front of two dignitaries. We have our CEO, Dr. Ashutosh Raghuvanshi, a very eminent, you can say, surgeon as well as the healthcare leader. And we have very, very eminent, a wholesome personality, not only in healthcare, but in cricket too. And that's Dr. Narootam Puri here as guest of honor. So chief guest and guest of honor are right here. And I'm very happy that they will listen to my lecture, otherwise many people will probably forget my lecture. So thank you, sir, for being here, and we'll start the inauguration ceremony right after this lecture. This lecture is very important because it is something of a milestone which I'm going to tell you. This is the Lancet. When were the last guidelines published for India? We published it. And morning, somebody mentioned, maybe Dr. Ashish mentioned, 2009. So 14 years later, we are going to unveil the new obesity guidelines. And it is acknowledged that the current proposed obesity guidelines are cross-fertilization of ideas from Lancet Obesity Commission, which I am involved in. And both are embargoed from press till publication in the Lancet and our journal, Diabetes and Metabolic Syndrome Clinical Research Review, respectively, and both will be unveiled for the first time in January of 2004. So what I'm giving you is a preview, a snapshot, or something which is coming in a proper printed manner. Preamble. Why are we doing it? Now this is the common minimal points of an Indian phenotype as compared to whites. And I've just not written here just like that. This is based on multiple publications from our group and several other groups. So we have lower BMI than the non-Hispanic whites, higher abdominal adiposity, higher liver fat, higher magnitude of insulin resistance and lower beta cell secretory capacity, lower age and BMI for onset of diabetes. Now this is particularly important because this was based 2009 guidelines. And rapid conversion from pre-diabetes to diabetes, higher inflammatory markers. This is also terribly important because whatever fat you have, you may be non-obese, but that fat is inflammatory. And higher nephropathy and cardiovascular disease, and that led to 2009 definition that Asian Indians develop morbidities at a lower BMI and waist circumference, and that's where Nawal, along with us and several others, made this guideline. These limits should be lower in our population than white population or any other population for that matter. So we lowered the BMI and waist circumference criteria in 2009, and that itself actually led to 3 crore more people at that time in the ambit of primary prevention. This is one of the most important steps for intervention, for prevention of diabetes. Just single change in definition. And now we are thinking whether that is correct. That is correct or not. Because body fat in Indian population has more inflammation. Now, I may have a BMI of 24 and somebody else may have a BMI of 24. I may harbor more inflammation and has more diseases than somebody else's body fat. It doesn't harbor any inflammation. Body fat is pretty clean. So please, at the back, please sit down. Please sit down. So, and this is particularly important for those with abdominal adiposity. Now this graph amply demonstrates why we made the 2009 guidelines. These are for 4 different groups. These graphs are occurrence of diabetes in the 4 different groups. South Asians at the top, then Chinese, then black, then whites. And this is the BMI. So, South Asians developed diabetes at 24 BMI, Chinese developed at 25, 26 is the black, and whites at 30. So what these people are developing at 30, we are developing at 24, and that's why we needed a lower BMI guideline to identify those who are at risk for diabetes. And this is a comparative data of non-obese people, non-obese, non-diabetic people. Non-obese, non-diabetic people, young, age BMI 22.4, and Indian were compared to Caucasians. And look at the hormone response, how different they are. Look at the adiponectin, which is markedly different. We have much lower adiponectin, meaning thereby our insulin resistance is markedly higher than the Western population. And the interleukin 6, which is higher at baseline state. Baseline state. You need not have a COVID-19 to look at interleukin. You do interleukin 6 in our bodies and it will be higher. So our bodies are different and our fat is more atherogenic. So revisions of definition for Indians, nuts and bolts of it. This was the consensus statement in 2000. Highly cited. Once it came out, it continues to be cited till now. And publication led to worldwide rethinking. Worldwide. When we published, everybody published. UK people published nice, and American people published based on our data that Indian population is something different and needs a different guideline. These are the guidelines. So cutoffs for overweight were 23 as opposed to 25 worldwide, obese 25 as opposed to 30, waist circumference 90 as opposed to 102 in whites, and 80 for women as opposed to 88. So they were lower in the Indian population. And they benefited as I said, large majority of people were benefited by this change in the guidelines. But then there are other people thinking other things. And maybe they are right. One of the group, which is led by my friend Aya Sharma from Canada, Edmonton group, they said that this is not enough. No, this is not enough. Just BMI is not enough. Now BMI may mean a wrestler. WWW wrestler may have a BMI of 35 and body fat of 25. And our people here at BMI of 24 have body fat of 35. So muscle counts and fat count, both count. Some people have more muscle at high BMI, so BMI is not accurate. Not accurate at all. So they staged it into 0 stage, 1 stage, 2 stage, 3 stage, and subgroups were metabolic, mechanical, mental, and milieu. All three have to be recorded in all stages. Seems to be very good plan, but very complicated. And when I sat in the Lancet Obesity Commission, when I think of this, I think of people who are sitting in Rajasthan somewhere in a small PSC. How will they do all this? They will not do all this. It's something not desirable. And so, whatever guidelines we make, it should be simple, widely applicable in all settings, reproducible, based on generally reliable evidence, based on general consensus, should be ethnic specific. This is what it should be. I keep on telling them in Lancet, and white people sitting in Harvard, etc., they don't understand. They don't understand even their own rural population and rural physicians who are sitting there. They only think of big things. Very difficult to convince those people. So Lancet Obesity Commission, we wrote the ethnic specific BMI waist circumference chapter on this particular, and this will be, as I said, will be. So Lancet Obesity Commission was in search for rational and simplified definition. After hammering them, well, simplified definition is needed. So this is. So unpack the ifs and buts and essential nuts and bolts. Relying solely on BMI? No, we are not going to do that. Relying solely on BMI may not effectively identify individuals with high body fat or predisposition to obesity-related diseases. Consider adding other measures of obesity to BMI? Yes, good idea. While alternative measures of obesity, waist circumference, waist height ratio have their advantage and drawback, combining them by BMI could enhance those who are likely to be at risk. And considering adding functional and mechanical symptoms, yes. So somebody who cannot walk because of high BMI, or somebody has a shortness of breath. So it's important to consider other functional symptoms when assessing obesity to achieve more comprehensive understanding of individual's health status. So part 3, revised definition of obesity, stage 1 obesity. 2 stages of obesity. So all of you who are sitting and seeing patients every day, there are only 2 stages of obesity. Henceforth, everything else is according to stages. Inoffensive is obesity, excess body fat alone without any adverse consequence. And stage 2 obesity, problematic. Abnormal anthropometry, excess body fat with adverse consequence. So, stage 1 obesity, BMI is still used to define generalized obesity, but there is no bifurcation who's overweight, who's obese. Above 23, everybody is obese. But in addition, you can do waist circumference and waist height ratio, but it's not essential. And body fat can be done, that's not essential. And should not have, these people should not have any symptoms suggestive or limitation of day-to-day activity. So they should be fairly mobile and no problem there. And any obesity-related comorbid disease. They should not be diabetic or hypertensive or something like that. So what are the examples? They say many of you may be in stage 1 obesity. You may have BMI of more than 23, but a 57-year-old man, BMI 28.5, can walk 5 kilometers per day at brisk pace. His blood glucose and other laboratory parameters are normal. So not many people, but yes, there are. And 62-year-old lady, BMI of 30.4, waist circumference of 90 cm, body fat of 38%, asymptomatic, does 30 minutes of aerobic and strength training daily, blood parameters correlate just a normal. Stage 1 obesity. They should be advised, they should be counseled, but something which is they are already doing, but needs to be ascertained that they are doing in the future also to offset some of the diseases. Stage 2 obesity. This pertains to increase in adiposity, both generalized and abdominal, affecting physical and organ function, causing functional limitation during day-to-day activity and resulting in comorbid diseases. So, 2 of the 3 criteria are needed. One is a mandatory BMI plus waist circumference or waist height ratio. So, BMI you should do, and simple is waist circumference, and you can calculate waist height ratio also based on that. Symptoms suggestive of limitation of day-to-day activities. I'll come to that. And a patient already diagnosed having obesity-related comorbid diseases, it should be recorded or may require reconsideration. What are the examples? What are the examples of obesity-related limitations? Shortness of breath, palpitation, musculoskeletal symptom, pain in the joint, etc. Obesity-related comorbid disease already know, type 2 diabetes, cardiovascular disease, obstructive sleep apnea, non-alcoholic fatty liver disease, etc. So what are examples? Simple examples. 65-year-old lady, BMI of 33 with osteoarthritis of knee, posing difficulty in walking. This is stage 2 obesity. A 50-year-old man having BMI of 39 with diabetes, hypertension, nephropathy and edema of feet. A 45-year-old man with BMI of 31 having dyspnea and palpitation on day-to-day activities. This is stage 2 obesity. So I hope you agree with me that this is a simplified definition. Anybody, anywhere, sitting in any clinic, in any village can do this. He has to have weighing scale, tape for measuring waist circumference, and just a questionnaire to ask. Simple. So this is my slide, last slide. Obesity is now defined as a BMI more than 23 kg per meter square. There is no overweight, no further. There may be gradation of BMI, which is fine, but obesity is not defined by that. Stage 1 obesity and stage 2 obesity. Stage 1 obesity, BMI equal or more than 23, mandatory. Optional, waist circumference, waist height ratio or body fat. No symptoms suggestive of limitations of day-to-day activity. No obesity-related comorbid diseases. Stage 2 obesity, BMI more than 23 plus, mandatory. BMI plus waist circumference and waist height ratio. Body fat is preferable but optional. Plus, obesity-related limitations in day-to-day activities, one or more, shortness of breath, palpitations, etc., or obesity-related comorbid diseases. If you have this one slide in your phones, you are done. Your understanding is complete. And this is what is going to be published in 2024 January. I'm very thankful to my 5 colleagues who have contributed to this, and around 70 people from all over India with whom we did Delphi survey to arrive at this. This is a path-breaking thing, this is a new thing, this is coming after 14 years, and this will change the way we look at obesity management, because here, in obesity 2, you will do very aggressive management. Whatever, even pharmacotherapy can be started at an early stage, besides diet and exercise. So with that, I thank everybody present here, full house. It's a pleasure to be talking in front of full house for this new thing, this something that I wanted to unveil in front of 400 people.